the organizers for inviting me, and I hope there will be interest in this topic. I will be talking today about the chromatic aberration and polychromatic image quality with hybrid intraocular lenses. And this work was done partly at the School of Ophthalmology at Indiana University and University of California, Berkeley. It was recently published in Journal of Cataract and Refractive Surgery, so you can access the article there. In the interest of disclosure, at the time that I worked on the study, my graduate stipend was in part supported by Alcon Research Labs, and Dr. Bradley, who is a co-author, also is a consultant to Alcon Research Labs, and Dr. Thibus does not have any commercial interests. So I'm going to give a bit of background in the difference between a conventional refracting lens and a hybrid refracting lens. So what you see here is a simple schematic of a biconvex lens, which could be an intraocular lens, and it's focusing incoming light rays on a single image plane. So there's a small schematic of the point spread function where the light is collected in a nice little peak, and there's good image quality for one particular distance. Now you could make the same monofocal lens a hybrid lens by making one of its surfaces refractive and the other surface a diffracting lens by putting etches on it, which is modeled after a Fresnel diffracting lens. And by combining the refractive portion of the lens and the diffractive power in such a way, you could obtain the same power for the total lens, and it would focus image at a single image plane. So that would be a monofocal hybrid lens. Now you could also have a bifocal hybrid lens where one surface is refractive, the other surface is diffractive, and the incoming light is split into a first order diffractive image and a zero order diffracting image. Now the big advantage of this design is that you can actually use it as a bifocal, because after cataract surgery, the patient will need near add power. Typically the zero order image is used as the distance image, and the first order image is used as a near image, and depending on the patient's age and requirements, the first order image, the add power is chosen in such a way that they can have optimum vision for their preferred working distance. So what is it that makes the same seemingly similar hybrid lens a bifocal or a monofocal? So we get a little bit more deeper into the optics of this lens. So let's look at the phase profile of the diffracting optical element here. So this is a magnified view of the etches that have been made on the glass surface of one surface of the lens. Now, if these etches are made in such a way that incoming light is delayed by one wavelength optical path distance, then that makes the lens a monofocal. However, if the same etches are made out in such a way that it causes an optical path delay of half a wavelength of light, that makes it a bifocal lens that splits energy equally between distance and near images. And the power of this lens, that is the add power of the bifocal lens, is determined by the ring geometry, by the diameter of the first ring of that echelet, and the wavelength of the incoming light, which is a unique property of diffractive elements. And this comes into play later when we look at the image quality with these lenses. So here we have a situation where the wavelength of the light actually affects the power of the optical element and therefore the add power of the lens. So what we are looking at here is the change in optical power as a function of wavelength. These lenses are typically designed for any one wavelength, which is typically 550 nanometers, because that's where the eye is most sensitive. And as you go for shorter wavelengths, the diffractive element actually becomes more hyperopic, and for longer wavelengths, the diffractive element becomes more myopic. Now notice that this is exact opposite of the refractive error of the human eye. The human eye also has longitudinal chromatic aberration. However, for short wavelengths, the human eye is actually more myopic, and for long wavelengths, it's more hyperopic. So this comes in really handy because you can actually use the diffractive optical element to correct for the natural chromatic aberration of the human eye by choosing an appropriate power. So you could use a 3 diopter lens, which would give a chromatic difference in power of 1.64 diopters. And you could use a 4 diopter lens, which would give a chromatic difference in power of 2.18 diopters. So in this manner, a hybrid lens could potentially be used to correct the chromatic aberration of the eye. So wavelength also affects the relative amount of light that is in the distance and near image. So what we are looking at here is light efficiency as a function of the amplitude of the phase step. So just like we looked at in the very first schematic, if you look at the far right, over here, if your lens causes a 2 pi phase difference, then all the light is in the first order and there's no light in the zero order. Whereas if the lens causes a pi phase difference, which it would at 550 or 555 nanometer, then about 40% of the light goes to the distance image and about 40% of the light goes to the near image. So let's look at what happens at 700 nanometers. So a lens that was designed to be a bifocal at middle wavelength light actually turns out that it has more light in the distance image and less light in the near image for longer wavelengths. And it has more light in the near image and less light in the distance image for shorter wavelength. So the optical engineers that designed this intraocular lens designed it to be a bifocal for one wavelength, but we go around in the real world looking at light of various wavelengths. And as you can see, the difference in energy efficiency is not the same as what it was intended to be. Here is the Alcon Restore bifocal lens, and this is a widely used commercial intraocular lens. It's a premium intraocular lens, I believe, and it is used as an alternative to have better near vision than a monofocal lens. So here is phase change as a function of pupil location relative to center. I'm simply showing the diffractive etches that are made in the back surface of the intraocular lens. And notice that there is actually a curved pattern to this etch. So it's not a uniform pattern, it's actually curved. And the reason it's designed to be this way is because for larger pupil size, the intention is that this lens should be more distance dominant than near dominant. And for small wavelength, for small pupil sizes, this lens is designed to be more near dominant. So when a patient is looking at near objects, the near triad comes into play, and their pupil constricts, and they are now looking through the center portion of this lens, which has more add power and more energy efficiency for the near image. And when they're looking at a distant object, pupil is more dilated, and distance image becomes more dominant. So that's the intent of the Restore lens, which is patented. So what is the purpose of the current study? It was to test whether the commercially available Restore lens can actually achromatize the human eye after implantation. That is, can it effectively correct the chromatic aberration of the human eye? And to evaluate whether through focus image quality in a model eye, pseudophakic model eye with the Restore lens implant is what it is intended to be while it was designed. So the optical methods that were used here are wavefront analysis. So what we did was we took a wavefront that represented the target vergence. The subject would be looking at different distances, and we would combine that wavefront with the corneal aberrations. I'm sorry, the graphic doesn't quite show the corneal aberrations here, but there's quite a bit of spherical aberration and coma. And the aberrations from the intraocular lens, which, as you can see, is concentric because it's diffractive. And all calculations were done at entrance pupil. And the way this would work is we would first generate a wavefront for every wavelength, because for each wavelength, the wavefront is different. And we would combine these monochromatic wavefronts. And if you inverse Fourier transform them, you would get the point spread function at the image plane for each wavelength separately. And then we would take a weighted sum of these individual monochromatic point spread functions, and we would weight it by the source spectrum. So the source could be anything. It could be an incandescent lamp. It could be natural daylight. It could be fluorescent. It could be any source spectrum that you desire. And we chose a D65 white spectrum because it's highly representative both of natural light as well as fluorescent indoor lighting. And we would weight it by the V lambda function, which is the well-known visual sensitivity function of the eye. The natural human eye is highly sensitive for middle wavelengths and loses sensitivity towards short and longer wavelengths. So this weighting makes it a polychromatic point spread function. So that's the point spread function of the eye for white light. And we would obtain image quality metrics from that point spread function, or we would Fourier transform it into the optical transfer function, which gives us the same information in the spatial frequency domain, and we would obtain image quality metrics based on that. So let me quickly explain what image quality assessment we did. So here is a typical Poinsett function, a very well-focused Poinsett function. And this is what we call an airy disk. And the size of this airy disk is determined by the wavelength of light and the aperture of the eye, the pupil diameter of the eye. So for each calculation, what we calculated was how much of the light does the restore lens send into the center of this bucket. So we would call this a bucket, and what is the light inside of this bucket. If there's a lot of light inside this bucket, that means that it's a pretty well-focused Poinsett function. If there's not much light in the center of the bucket and more light is bleeding out to the edge, that means there is a lot of blur in the image. So the light in the bucket gives us a metric of image quality. And we picked a 3.75 millimeter diameter pupil because that's kind of ambient pupil size for most people. And the effective add power of this lens is 2.9 diopter. We calculated image quality for target vergences ranging from about 20 centimeter to infinity. So here are the results. I'm going to show you light in the bucket, which is the metric that we used, as a function of target vergences going all the way from infinity to 20 centimeters. So let's first look at red. There are lots of things to notice here. So the first thing here is the fact that the light is a lot more in the distance image than it is in the near image. So remember, that's what we looked at when we looked at the schematic with the calculation with how phase step actually affects light efficiency. So when a patient wearing this lens is actually looking at red light, a lot more of that light is actually going into the distance image than the near image. The other thing to notice is that the peak image quality is actually not at 0 diopters, which is infinity. It's actually a little bit more positive than that. So for the distance image, the chromatic aberration of the eye actually causes peak focus to shift to the hyperopic side for distance, and it causes the peak here to shift a little bit to the myopic side for near. So the power of the lens is also dependent upon the wavelength. Now let's look at the design wavelength. So this is what the lens was actually designed for. It was designed to be a bifocal at 550 nanometer. And once again, the light is more for distance than for near because this is the restore lens. It uses the phase apodization design. It's intended to be more distance dominant. However, now the power of the lens is what it was actually designed to be. The peak focus happens at 0 diopter, which is what it's supposed to be. And here in the near add power is about 3 diopter, which is what the lens is designed to be. And let's look at the blue light. So this is pretty big deviation in the blue light. So for blue light, the eye for the distance image is a lot more myopic, and for the near image, it has actually been, the chromatic aberration has actually been corrected and a little bit over corrected. So the eye is actually a little bit more myopic for blue light for the near image now. The black line represents image quality for white light. So for white light, you notice that there is a drop in image quality from what it is for 550 nanometers, and the reason is because of this big chromatic aberration that's happening here, this shift in refraction due to refractive chromatic aberration. However, the white light image quality for near is pretty good because of the benefit of chromatic correction using the restore lens. So the difference between red and blue for near is not as big as the difference between red and blue for distance. So there's chromatic cancellation happening at near, and that benefit is seen in white light. So we look at contrast as a function of spatial frequency, starting from low spatial frequency, which is less details, to high spatial frequency, which is a lot of details in the image. This just shows the diffraction limit at reference, which is the best achievable at that wavelength. And here is what a monofocal lens, a typical conventional intraocular lens would look like. It would have pretty good contrast at low spatial frequencies, and contrast would drop off at high spatial frequencies. And this is what the restore lens looks like for distance. And if a patient is wearing a monofocal intraocular lens and they're looking at maybe a newspaper at about 30 centimeter distance, their contrast is near 0 by the time they get to 10 cycles per degree. So that's a lot of blur. Whereas if they were wearing a restore lens, they would have pretty good contrast from 10 cycles per degree, which stays uniform all the way up to about 30-40 cycles per degree. So the restore lens does give benefit for near focus. And these are examples of simulated images in an aberrated eye model. So this is how a letter chart looks like with a 3 millimeter pupil at distance with the restore lens. and this is a near chart. There's two things to notice here. The first thing is the 4.5 millimeter images are more blurred than 3 millimeters because of the optical aberrations. The other thing to notice here is that the near image, while it looks like it has defined edges, actually has lower contrast, and the reason is because the restorer lens is designed to be distance dominant. So 4.5 millimeters, it's a lot darker for distance than near. So this is something that clinicians might want to keep in mind while they prescribe. So just to conclude, a Fourier optical model of image quality metrics actually does a pretty good job of predicting all the optical properties of a diffracting lens that's laid out by theory. And the restorer lens actually does achromatize the near image, so it actually effectively corrects the chromatic aberration of the natural human eye. And predicting the balance between distance and near image quality actually requires an analysis in white light, because monochromatic analysis does not do a good job of predicting this balance. And the design wavelength predicts refraction. And lastly, the effects of the restorer apodization are very prominent even in white light. So even for white light, the restorer lens is distance dominant. So I'd like to finally acknowledge Dr. Bradley, Dr. Thibus, Dr. Zhao Zhang, who is the research director of Alcon Research Labs. He's not there any longer. And Dr. Shin Hong, who's currently actually the research director of Alcon Research Labs. Thank you.
So we'll allow one question. Yes, ma'am.
Get the restore are very unhappy, and maybe there's a 1% explantation. What can be done about that, or why is that happening?
So the first question is, why is that happening? There's a couple of things that we might think about. First is although there is a good image efficiency split for distance and near, the contrast is pretty poor. So the contrast sensitivity function does suffer. And this might be a particular problem in low illumination. So they might be unhappy while they're driving at night. They might be unhappy when they are sitting in a room with low illumination. For whatever reason, they might be functioning a little bit more in dim light and unhappy with that. I would think that a patient with a restorer lens would be happier if they are largely performing under photopic conditions. So that's one possibility. The other possibility is there could be glare if the diffracting lens has not been placed just right. If there is any tilt, the glare is more defined because there are very fine etches in the diffracting lens, and that could actually cause greater glare than a conventional intraocular lens. As for what could be done to fix it, I'm not sure about that, but one of the things that we looked at while we did this study and some follow-up studies with this is there a way that we could actually show the patient how their vision would be before they actually underwent their surgery, so that they have some level of idea of what they're getting into. They may come in expecting that they would have perfect vision for near, and it would be necessary to explain to them that this is a compromise from wearing an ad externally. So that's one possibility. So thank you.
Thank you very much. Appreciate it. What I do, actually, what you showed that the pupil size does play a role, is sometimes if I have at least a few patients every week coming complaining out of restore to my clinic, and my very first thing is I actually give them an alpha GAN or a combi-GAN drop to just give them a little bit of a myotic pupil, just to decrease the pupil size a little bit, and that can improve the image quality a little bit. Mm-hmm. So that is just my very first to go in a multifocal unhappy patient lens.
Is there